So your wound care journey does not have to be the doom spiral that it currently is. My name is Dr. Meredith Warner, and I'm an orthopedic surgeon in Baton Rouge. So what is the diabetic foot? Well, the World Health Organization in 1995 defined it as such. And I quote, "The diabetic foot may be defined as a group of syndromes in which neuropathy, ischemia, and infection lead to tissue breakdown, resulting in morbidity and possible amputation." So what you need to remember is there's neuropathy, which we just talked about briefly, ischemia, which is a lack of oxygenated blood flow to the foot, and then infection. So obviously all three of these things, particularly if they happen together, are gonna result in abnormal tissues that can't heal properly. Then you get the breakdown, and then ultimately it leads to ulceration, and ulcerations more often than not can lead to amputations. Now, my goal in my clinic is limb salvage. No matter what, we try to avoid amputations if at all humanly possible. So Charcot is when you have breakdown of the bone, deformation of the foot structure itself, increased areas of contact pressure, tight contracted tissues, and the inability to heal minor trauma. And then the trauma just causes more trauma, which causes more trauma, which eventually causes all the foot bones to fracture and dislocate, and it's just a disaster. This is not a peripheral arterial disease problem. In fact, these patients usually have a ton of blood flow. In fact, it's hypervascular, and it is extremely easily missed initially. I can't tell you how many diabetic patients with a deformed foot I've seen where they had a simple little sprain, they stepped off a curve wrong, and everyone just treated it like it was nothing's wrong. Oh, you just have an ankle sprain, don't worry about it. If you have a diabetic with neuropathy and you have any type of minor trauma, you need to go see someone that understands Charcot arthropathy, because it needs to be immobilized and managed immediately to prevent the breakdown from happening. And it is extremely easy to miss. It's missed all the time, and I don't want that to happen to you. So your wound care journey does not have to be the doom spiral that it currently is. Remember, the wound care business model is repeated debridements and product markups, okay? So I wanna get you out of that doom spiral. This image is showing you the planning of an adipofascial cutaneous skin turn down flap based off of a pedicle. What do I mean? Well, all the arteries in your leg have certain branch points where they feed the skin and the muscle and the fascia around them. Those are called perforators. So if you can identify a certain perforator, you can build a rotation flap around that, move that vascularized normal tissue to where it's not normal, get that ulcer to heal, and then you can just skin graft or close where you took the donor tissue, okay? This is a highly effective method. It does not require a free flap. Some wounds do require free flaps, but this is just moving tissue around in a very precise and elegant way. I do this in my clinic for people, not in my clinic, in the surgery center, obviously, but we are able to offer this. So remember, a lot of your wound care clinics don't have this capability. They don't even know to think about this. So I just want you to know that this is a possibility, and if you have one of these wounds that's just not getting better, not getting better, not getting better, you may want to go find someone that is trained and able to do orthoplastics techniques like we can at Warner Orthopedics.